Drastic U.S. aid cuts in January 2025 hit African countries hard. They were left scrambling to fill the funding gaps from shrinking national budgets while pushing for health sovereignty. So what has changed, and who is paying the public health bill now? One in three people, or more than 423 million Africans, struggle to pay for their healthcare bills out of pocket, according to the latest WHO data. Only 3 countries, that's Rwanda, Botswana and Cape Verde, have consistently met the Abuja Declaration target to spend at least 15% of their national budgets on public health care. More than half of the 54 African countries spend less than 10%. Since 2021, external health aid to the African continent has dropped by nearly 70% as donors reduce funding, while disease outbreaks increased by more than 40% between 2022 and 2024, including recurrent outbreaks such as mpox, Ebola and cholera. Now, even though some African countries can now handle some vaccine production, like filling vials and packaging doses for distribution, more than 90% of vaccines and medicines used in the continent are imported. So who was paying the public health bill? Well, between 2022 and 2023, about 21 African countries were relying on the U.S. to fund at least 20% of their national health budget. But in Somalia, South Sudan and Malawi, American aid exceeded government spending by more than 200%. And in Uganda, donors supported HIV/AIDS treatment programs that allowed the flow of essential medicines to people living with the disease. But that stopped when aid dried up, as Darren Alan Chayune found out in Kampala.
Lilian Chihomoro has lived with HIV for 29 years. This social worker relied on life-saving drugs provided by the US government. But in January, President Donald Trump's executive order to freeze foreign aid caught her off guard.
I was given medication for 6 months, and the explanation was we are closing for now, and we're not sure when next, so it's better you take this medication. And that traumatized me.
Last year, USAID had reserved about $4.2 billion for healthcare in the continent. And since 2003, the US President's Emergency Plan for AIDS Relief, PEPFAR, has invested most of its $110 billion in Africa. It used to cover all activities run by the Uganda Young Positives, which coordinates young people living unaffected by HIV and AIDS. But this 22-year-old community-based organization has had to reduce its staff by half and abandon its 2-year strategic plan.
We had envisaged also expanding our community dialogues in terms of educating the young people in treatment literacy. We can't do that anymore.
Many individuals who are working in critical support in Uganda have either paused or entirely moved on to new ventures. Quraish now spends more time here at his driving school business, unlike before the American aid funding cuts. UNAIDS says that the number of people using HIV prevention medicine has fallen by 64% in Burundi. And in Cameroon, HIV tests declined by 43% in the first 7 months of this year. African countries are prioritizing domestic financing to raise at least 15% of their budgets towards health. And the Ugandan government says it has signed a new $2.3 billion 5-year agreement with the Trump administration.
Previously, we were seeing a lot of financing going through third parties, and sometimes you would not know how much of that money has done some things in the country. But in the next phase of engagement, we are going to see more government being in charge.
This gives people like Lilian, who live with HIV, hope that they will continue to receive life-saving drugs. Darren Alan Chayune, Africa Matters, Kampala.
African leaders are now calling for health sovereignty, which would mean paying for public health without donor support, pooling resources and investing in regional manufacture of medicines and vaccines. In the meantime, some countries have signed new bilateral health deals under Donald Trump's America First model, which requires increased local spending and channels funding through governments rather than aid agencies. Let's take a look at some of them. So in Uganda, the United States says it will invest $1.7 billion to combat HIV, AIDS, tuberculosis, malaria, and other infectious diseases, while Kampala Core invests around $500 million. Washington has also signed a 5-year agreement with Lesotho that will provide up to $232 million to combat HIV, AIDS, and strengthen the healthcare workforce, while Maseru will invest $132 million. The U.S. has pledged to give $125 million to support the fight against HIV and AIDS. Again, malaria and maternal mortality, while Liberia will boost it with $51 million. But Kenya's deal with Washington has drawn controversy. The U.S. committed to provide $1.6 billion, while Nairobi invests $850 million to invest in domestic financing. But the fate of the agreement is now uncertain after Kenya's High Court suspended it after it received petitions over data privacy and procedural problems. And on the sidelines of a U.S.-led peace deal between Rwanda and the Democratic Republic of the Congo, Washington pledged $158 million to Rwanda's fight against HIV and AIDS, while Kigali adds the remaining $70 million. And joining me to unpack this is Dr. Githinji Gitahi. He is the Group Chief Executive Officer of Amref Health Africa, and he's based in Nairobi. Thank you very much, Dr. Githinji, for making the time. Just straight on, are African governments paying their public health bill after U.S. aid cuts this year? And are they any closer to getting health sovereignty?
Thanks for having me. And that's a complex question. I think the first thing to ask is, what is self-sovereignty? And there are two elements of this question. One is sovereignty on the programs, on the health strategy, and that is the most important sovereignty. What is it that matters to the African people, and therefore what is it that the governments need to do? The second thing is financial sovereignty, which is what people tend to focus on. So financial sovereignty, in reality, 80% of all health services are paid for by African governments and their people. That doesn't mean they are paid by government through taxes. It means that people suffer paying out of their pocket and government supplement, or vice versa. And the donors do only 20%. So if you're talking about financial sovereignty, health is paid for domestically in majority of countries. It is just that it's inadequate and it's coming out of people's pockets. And this is the challenge. So are governments paying their public bills even after withdrawal? They are paying their bills, but suboptimally.
But I mean, over the years, we've seen so much dependence, particularly on the United States, and I'm talking about the U.S. aid. And then we just saw the African Health Sovereignty Summit, I believe, in Accra, Ghana, and the leaders there agreed they want health and not aid. How would that look like? Because the truth is, there are countries, Somalia, South Sudan, Malawi, that have had an over 200% dependence on the United States for aid.
So there are countries, the countries that are extremely poor and countries that are in conflict that depend more than 50% of their health budget on aid. Some of them is 52%, others is more than that. Majority of countries in Africa depend on aid between 15 to 25%. The rest of it is domestic through out-of-pocket expenditure and government taxes. Is this money enough? Let's probably frame the question and ask, when we talk about dependence on aid, the African government, let me take a case of a typical African government like Kenya. And I will say that the actual expenditure on health by the entire country per person is $100 per person. And out of that $100, about $43 is government taxes. About $20 is donor aid, is development assistance, including the US. And the balance is paid for by households out of pocket. That's a typical case. So the question of over-dependence is actually what I would say is actually misrepresentation. It's overrepresentation of the donor contribution to multiple countries. It is normally 15 to 20%, but it is so focused on because it's dealing with a very critical part of the health system, which is infectious diseases, HIV, tuberculosis, and malaria. But generally, health financing is done by the people out of pocket and governments, which is completely inefficient. Now, the question then is, who are they relying on in the absence of the US? They're having to drop some of the functions that were being paid for by the US. Other governments are increasing their money to try and cover them. But the bigger question is, with or without the US government, is the health financing in Africa adequate? And the answer is no, it's not, because the African economies are too small for their population, and donor aid cannot replace all the money that's needed. You know, in Europe or North America, the expenditure is $4,000 per person per year using government money. In Africa, you're talking $40 at best. So, and that is based on the economy and population. And you can't make $40 to be 40, but to be 4,000 with donor aid. So donors are only supplementing the already inadequate finances available in the country.
Right, and you said it, health financing across the continent is not adequate. Your own words, Dr. Githinju there. So I would like us to talk more about that and how we can solve that, how we can fix that as a continent, as we also talk about what other public health systems need fixing and how that would actually work across the continent, of course.
So thank you for that. The way to fix the health financing is that on one side, there is actually what I like to call a fiscal capacity problem. To give you a valid example, if you look at the African continent, it has 1.5 billion people. The total GDP of the African continent is just slightly above $2 trillion. Now, take Germany. With 80 million people, their GDP is more than $4 trillion. So there is no amount of accounting that is going to lead Africa to spending the same amount of money on health like Germany. And that case can be used for the US, for anyone else. That Africa's economy is too tiny. It's only about 3% of the global economy with 17% of the world's population. So there is no money. And I think that should be the conclusion, that Africa as it is right now cannot afford a healthcare model. So what do we do and what systems need to be fixed? The system that need to be fixed is avoidance of disease. It's prevention. It is health production. And Africa can afford health production because Africa has agriculture. Africa can provide healthy foods to its people. Africa can avoid the trajectory of obesity and other challenges that rich countries have gone through by ensuring we have proper food regulation of fast foods that are coming into the continent, and families are transitioning nutritionally from healthy foods to unhealthy foods. Those need to be regulated. Africa can ensure that we produce health because we will never afford disease. And that's the reality. Even governments that increase 15% of Abuja still end up with $40, $50. So you cannot afford $4,000 that Germany and Europe is using, or US is using $5,000 by increasing to 15%. You'd have to use your, even if you allocated the entire budget to health, you'll still not afford $4,000 for health because the per capita income in most African countries is less than $2,000. So what is 20% of $2,000? What is 15% of $2,000? You can never get to where Europe and America is. So we have to follow a different path, and that path is producing health, not treating disease. That's a system change that's needed.
Producing health, not treating disease. That could take a while, right? Before we produce our own food, like you're saying, depending on agriculture, Africa being very rich in arable land, for instance, and that could solve this entire process. But that takes time. What are the solutions that can be provided or can be done now? Because it is a matter of urgency.
Yes, and I can give you a few of them. There are certain things in the health sector which produce health without having to wait a long time. For example, I just gave you an example of fast foods. If mothers are consuming fast food, they are consuming high sodium to their children. They're giving fast food to their children. They're going and buying chicken for their children. The children get obesity. By controlling the industry, ensuring the foods are labeled properly, what we call front of pack labeling, and ensuring that you tell mothers where there is excess sugar. Therefore, it will change behavior, and that doesn't take long. And therefore, you can start getting families to feed their children healthy food and avoid childhood obesity, which eventually is what ends up in cardiovascular disease. That's one example. The second one is actually looking at vaccination. Cervical cancer kills a lot of women and consumes a lot of health budgets. But we know that science has given us a solution. If you provided HPV vaccination to every girl by 15 in every country, you would eliminate cervical cancer, and therefore you don't have to spend money to treat it. So there are many such examples, even as you wait for the longer term the longer term gains.
Right, indeed. And as we wind up, sir, in just a minute, what's your assessment of the bilateral health agreements made with the United States, seeing that they're actually transactional under Trump's America First policy?
So we know that the money that the US is giving to the countries is significant. As I said, for a country like Kenya spending $40 of government money per person per year, receiving $5 from the US, $5 in addition to the 40 is significant. So I would not expect any government to turn away the money. And I think that it would be wrong to do that because it means that the money is coming to build health systems for the people and the government is responsible. So the government has to be pragmatic. The challenge that we are having is the exchange metrics. That the US government is saying, this is the money, but we want your data. So I think the most important thing is data governance. That those bilateral agreements must do two things. One, the data governance must be respectful of multilateral agreements. The WHO has discussed how data should be governed, including specimen data and data on pathogens, and those agreements should follow the principles of the multilateral agreements, of which these countries that are signing the agreements are members of. So they should lead that. The second thing, they should use their local laws, because in these countries, there are laws that protect data, that actually protect data privacy, and those laws should be used in signing these agreements. What we've seen is kind of delaying the implementation of those laws and saying we'll negotiate in future. My request to countries is negotiate the data privacy laws according to your national laws immediately before signing the contracts. And secondly, embed the principles of multilateralism that protect pathogen sharing and include benefits to the countries that share pathogen data.
Right. Thank you very much, Dr. Githinji Gitahi, there, Group Chief Executive Officer of AMREF Health Africa. Thank you for your time and your contribution, sir.
Thank you.
We head to the city of Goma in eastern DRC now, which has been occupied by the M23 rebel group since January this year. Armed conflict and the humanitarian crisis has made access to vital health centers unpredictable. Pregnant women are finding it especially hard to get prenatal care, but a simple and revolutionary innovation is helping midwives. Zanem Neti Zaidi has more.
Leah is about 8 months pregnant, but hasn't had any medical checks. She lives in a part of the DRC that's been devastated by fighting and can't afford to go to a doctor. But that changed when she could see her baby using a probe connected to a phone.
I think this technology is a good thing because it makes life easier for pregnant women like us who can't afford to have an ultrasound scan. These days, it's hard to find enough food to feed the family, so finding the money for an ultrasound scan is simply impossible. Now it's easy to monitor the development of my future baby. It's a beneficial innovation for us women.
The hospital sees around 20 women who come to monitor their pregnancies. The digital ultrasounds are helping midwives detect pregnancy complications early and reduce maternal and infant mortality rates.
Before we had this device, we used to perform examinations without much precision. But now we can conduct consultations and examinations with precision and confidence, since we can see everything with our own eyes.
Latest data from the United Nations Population Fund shows that more than 2,000 women in North Kivu province benefited from this technology between 2022 to 2023. It was developed specifically for women living in hostile environments, with a focus on costs, mobility, and robustness.
This technology was developed primarily to support healthcare providers who are in the most remote areas and do not have access to the equipment needed to provide services to women and pregnant women.
The United Nations hopes to deploy these mobile ultrasound machines in other provinces across the country to help keep mothers and babies safe despite what's happening around them. Zanem Neti Zaidi, Africa Matters, Goma, DRC.
But Congolese women have a new battle on their hands. A free childbirth assistance program has been discontinued amid the conflict, putting many pregnant women in the country's east at risk. Rahul Radhakrishnan tells us more.
A free, government-sponsored, World Bank-backed maternity care program had helped expectant mothers across the Democratic Republic of the Congo for over 2 years. But now the program has ended. And in the rebel-held East, it's putting many women in a predicament.
I am seeing many women giving birth at home now because they can't afford it. They don't know how to get the hospital to deliver because they ask for a lot of money. I just found a small opportunity to come here for prenatal care because before I gave birth by C-section and I paid a lot. I came only for this consultation, but I am almost due and I don't know where I'll get the money to pay.
The M23 rebel group calls the program a failure without elaborating. The Kinshasa government has not said why the program was not renewed.
It was a good project because it even helped us boost our maternity statistics. At the time, we were handling between 8 to 5 deliveries, but with the project, we went up to 20 deliveries per month. We noticed it was a good project for us because it helped women come give birth at the health center without difficulty, since they knew that by going to hospital, everything would be provided for free.
But the conflict between the rebels and the government since the beginning of the year has made access to vital medical supplies difficult in the East. Basic infrastructure and the economy have collapsed.
We started at 20 deliveries, then 17, and then it dropped. We are already down to 9. There has been more than a 50% decrease.
The DRC already had one of the highest maternal and neonatal deaths in the world. The childbirth program was a bid to save more lives.
When I go into labor, I wonder where I will find the money. We don't have jobs. What's more, there is no longer any free healthcare. We wonder how we are going to manage. In any case, we need help from the authorities because we risk dying at home as a result of hunger and the pregnancy.
Most Congolese live on less than $2 a day. They now have to pay for the healthcare they need. Rahul Radhakrishnan, Africa Matters.
To Sierra Leone now, which has declared that the mpox outbreak is officially over. About 60 people have died and thousands were infected. As the country recovers, many survivors are navigating the quiet pain of being shunned and stigmatized by those around them, as Brenda Zederadido reports.
When Sierra Leone reported its first case of mpox in January this year, the government declared a public health emergency. And Nelson Johnson was among those who caught the deadly virus. Despite recovering, he now battles the stigma associated with it. So he joined other survivors in fighting discrimination with awareness.
It's because maybe the person is being caused, it's because the person has a lot of boyfriend, this mpox is not real, or this mpox is just a chicken pox. So you find out people are not ready to accept it, unless when we decide now to go to the community and explain to them that I've been affected, I'm now a survivor. It doesn't mean that I can affect you again. So that is the only way people start believing that mpox is real.
The mpox virus originally spread from animals to humans, but it can also be passed through people. It causes flu-like symptoms and an itchy, painful rash. For some mpox survivors, misinformation has been making their lives harder.
It's not really easy for me.
Things are not easy for me. Even a place to sleep I don't have. Food to eat I don't have. At my workplace, when they knew I had mpox, they didn't allow me to return. Up till now, I'm searching for a job. It's not easy for my life.
Sierra Leone recorded nearly 5,500 cases and 60 people died since January. Health officials say the vaccinated frontline health workers and people taking care of those infected while spreading awareness about the virus.
This response is not only focusing on case management. You find out that there are other pillars that were involved in this response. We have the psychosocial, we had also the logistical aspects, security, but the psychosocial case management were paramount, and we tried to make sure that we had all what it needs, to combat the epidemic, the mpox.
The World Health Organization says at least 28 African countries recorded more than 42,000 confirmed mpox cases and nearly 200 deaths this year alone. Sierra Leone has now officially declared that its mpox outbreak is over. For Nelson and his fellow survivors, the lesions on their bodies not only mark survival, but they are also a reminder to turn their pain into promoting awareness. Brenda Zeda Radido, Africa Matters.
That's our show this week. Let us know what you think about Africa's health sovereignty or other stories you've seen. You can leave your comments on our Africa Matters YouTube page or on X. Thanks for watching, and it's goodbye from me, Grace Kuria Kanja.